This is Lecture 3, Part 2, and we're on congenital heart defects. So this is just a little reminder of the fetal circulation changes that happen at birth. Remember, in utero, there's an opening between the right and left atria, right, the foramen ovale, and then between our pulmonary artery here and our aorta here, we have an opening right there, the ductus arteriosus. In utero, the pressures are higher on the right side of the heart, so blood's going to go from where it's high pressure to low pressure. So it's going to cross from right to left through that foramen ovale, and again, we still call it right to left because it's the right side of the heart to the left side of the heart, from the pulmonary artery to the aorta. Because in utero, the lungs don't oxygenate the blood, so we don't need that much blood to the lungs. After the baby's born and they start breathing, the pressures change quickly, within hours. The pressures should change so that the right side of the heart is lower pressure, the left side of the heart is higher pressure. And that is a big part of what closes, initially closes those shunts, those fetal shunts. And then the other one's down here from the umbilical cord, and when you no longer have a placenta, that one quits working. So, heart failure in children, this happens from impaired myocardial function. So what you're going to see is tachycardia. Children can't change their stroke volume. Adults will try and make up for decreased or just problems with circulation by increasing the stroke volume. Kids can't do that, so instead they go faster. If they're not getting enough blood pumping, they beat faster rather than more. So tachycardia, fatigue and weakness, they're not meeting their metabolic demands very well. They have no reserve, so they get tired easily. Often act restless because they're a little air hungry. Pale, cool extremities, decreased blood pressure. That's very late in children. They usually can maintain their blood pressure until they can't, and that's late. Decreased urinary output, that's pretty significant. If we're not getting good perfusion to the kidneys, urinary output will decrease. Pulmonary congestion. So if the left side of the heart is backing up into the lungs, we're going to see pulmonary congestion. So tachypnea, dyspnea, respiratory distress, exercise intolerance, again, that inability to manage any sort of exertion. They just can't compensate for it. And cyanosis, if we have issues with oxygenation. Systemic, so this is right-sided heart failure, right? It's backing up into the body. You get your edema just like you do with adults. Edema in adults tends to be dependent edema down in the ankles and stuff like that. Kids, it's wherever the tissue is spongiest and stretches out. So peripheral, and I'd say especially fingers and toes, and periorbital around the eye. That's where it puffs up really quickly and easily. Weight gain, this is probably our best assessment tool of how much extra fluid this child has. How much weight have they gained? Ascites, hepatomegaly, enlarged liver, neck vein distension. Okay, they've got to be old enough to see their neck veins. On an infant, you can't see the neck veins. So our congenital heart defects, we used to classify them as cyanotic or acyanotic, meaning you don't send deoxygenated blood out to the body, or you do send deoxygenated blood out to the body. We don't really like using those terms anymore because the problem is the kids, even some of the cyanotic defects, they would look pink, and if they got into enough heart failure with the acyanotic ones, they can look cyanotic. So what we really prefer to use now is a left to right shunt is acyanotic. We take blood from the lungs, send it back to the right side of the heart, send it back to the lungs. Then a left to right shunt is what we used to call cyanotic. So blood returning from the body bypasses the lungs and goes back to the body, so it never gets oxygenated. So we'd prefer right to left or left to right shunt now. And then we further classify those by the hemodynamic changes that happen. So increased pulmonary blood flow, sending more blood to the lungs, right? Decreased pulmonary blood flow, not sending blood to the lungs. Obstruction of flow, so it can't get out, and then mixed. So for those increased pulmonary blood flows, atrial septal defect, ventricular septal defect, and patent ductus arteriosus, and we'll just quickly look at those. So here's the septum, right, divides the right and the left side of the heart. So atrial, and remember the left side is higher pressure within a few hours after birth, so blood's going to move from the left atria into the right atria. So it's already been oxygenated, it moves over here, it goes to the lungs again. Same thing, but down in the ventricle. But again, pressure's higher over here, so the blood's going to go this way. So we've got that left to right shunt. We're not sending deoxygenated blood out to the body. Atrioventricular canal, this is an ASD and a VSD. So actually what it allows is all four chambers have communication together. This is the most common defect for kids with Down syndrome. As long as all the pieces of the valves are there, this is very easily repaired. And the ASDs and VSDs, some of those will close on their own, and ones that are too large and need repair, very good repair with good prognosis, very low risks on those surgeries. I mean, it's a big surgery. It's an open heart surgery, but the kids do really well. Patent ductus arteriosus. Remember, this was that connection between the pulmonary artery and the aorta. Should close, start closing within hours after birth and be pretty fully closed. It closes, but then it has to like structurally harden, and so that takes a few weeks. But it stayed open. Again, the higher pressures in the aorta, so you're going to get what was from the left side of the heart moving to what's from the right side of the heart. So it's still a left to right shunt. Now our obstructive disorders, these tell you what they are. Coarctation of the aorta. Coarctation means narrow. So this is a narrow place in the aorta. Aortic stenosis. Stenosis means a abnormal, a tight, small valve. So your aortic valve is small and not working, or your pulmonary valve small and not working. Right, so this is what we usually see with coarctation of the aorta. It's usually here after your carotid and subclavian have come off. So blood from the left side of the heart here comes up the aorta, goes to the head and the arms, and it's really hard for it to get through the skinny place, so more goes up to the upper part of the body than what gets through here. And then when it gets through this narrow place, then it widens out, so the pressure drops really low. So with this defect, you're going to see high pressures in the arms and low pressures in the legs. So if we do the blood pressure upper extremity, lower extremity, this one will be high, the lower one will be low. Problem with that is your kidneys in that lower part, right? Kidneys say, we don't have enough blood flow. We need to raise the pressure. Stenosis means a narrowed valve. So this can be a big surgery if the valve is a mess, but if the valve is really good, sometimes they can just do a cardiac cath and put in there and stretch out the tight part. Sometimes not all the valve pieces are there and they've got to do an artificial valve. So it totally depends how serious this is or how big the surgery is. Right, but here we've got a narrowing on, this is on the aortic arch here, right? So this is aortic stenosis, and this one's pulmonary stenosis. This is the pulmonary valve, the right side of the heart up the pulmonary artery. Things that cause decreased pulmonary blood flow. Tetralogy of Fallot and tricuspid atresia. You notice those both start with the T's. We call them the terrible T's. Anything that starts with a T and a cardiac defect is bad. So tetralogy of Fallot, tetra means four. So actually the four pieces to it, we have a VSD, right? So the right and left ventricles with an overriding aortic arch. So not just is there an opening between the two, but the aortic arch makes it really easy for blood from the right side of the heart to go up it. And there's pulmonary stenosis, so blood comes into the right side of the heart, hard to go up that pulmonary artery and easy to go up the aorta. So we're taking deoxygenated blood, sending it back to the body. And then the fourth part of the defect is you get this right-sided hypertrophy. Just comes from trying to pump up that pulmonary artery. Tricuspid atresia. Atresia means not there or totally non-functional. So the tricuspid valve is not there or totally non-functional. There is no connection between the right atria and the right ventricle. In utero, this child will have an ASD and a VSD. There's no other way to survive through, for a fetus. So blood comes into the right atria, crosses over to the left atria, mixes with what's coming into the left, down to the left ventricle, and then some blood goes up the aorta, some crosses over to the right ventricle and goes up to the pulmonary. Right, so we have taken deoxygenated blood and sent a bunch of it back to the body. These right to left shunt defects, you can't treat them with oxygen. Oxygen will not help because the blood is not going to the lungs. Mixed defects, so this is mixing of blood, transposition, total anomalous, notice we still have those T's, right, so bad, and then hypoplastic, heart syndrome, that's the only one that doesn't start with a T, so that's the only one you have to remember is really bad. Everything else, if it's really bad, it starts with a T. So transposition of the great arteries, this means the aorta comes out of the right side of the heart and the pulmonary artery comes out the left side of the heart. So blood comes from the body to the right side of the heart, to the aorta, to the body, to the right side of the heart, to the aorta, to the body, to the right side of the heart. Not right. Then the left side of the heart goes to the pulmonary artery to the lungs, back to the left side of the heart, to the pulmonary artery to the lungs. So we've got two separate circulations. In utero, this baby grew and did okay because of the shunts. After birth, they start looking terrible. This is your baby who maybe had a 1-minute APGAR of 9 and a 5-minute APGAR. It's down to 5. And putting oxygen on them doesn't help. They need surgery and they'll literally do a switch. Switching these to where they should be. It's a big surgery and that's fairly big risk. Total anomalous pulmonary venous return. So from the lungs, there are 4 veins that return to the left atrium. Total anomalous means they all 4 go to the wrong places. None of them go where they're supposed to go. How bad this is depends on where they go to. But usually it's pretty bad. Some of them may actually be too short to get them where they need to go. And so now we've got to use, add in baffles that are not natural, which means you're at risk for clotting, which means we're putting you on anticoagulants. And we're talking about neonates. Hypoplastic left heart syndrome. Hypoplastic means one of our ventricles did not develop in utero. If you're only going to have one ventricle, you're better off with a left than a right, but hypoplastic left means you have no left ventricle. We can never make that ventricle. This is actually 3 surgeries that they stage in, about the first 4 to 6 years of life. They do one shortly after birth, one at 6 to 8 months when the baby kind of quits growing, and then another one when they're a few years old. But this child will always have 3 chambers to the heart. We can't make that other ventricle work. They do surprisingly well, but they have just no ability to compensate. They get a little dehydrated, they come to the hospital. They get a little fluid overloaded, they come to the hospital. They'll probably be on a fluid restriction for life. These kids, by the way, we only started repairing these maybe 20 to 25 years ago. So the oldest ones now are just entering the adult world and adult cardiologists.